I'm delighted to be part of this phenomenal group led by the editors, Nicola Bonet, Professor Philip Orendelli, and Vikas Kanduja to put together this book, Hip Preservation Surgery. I had great fun in contributing to the book. I work out of Cambridge and London, and we work as a team of friends, which is formed of the European surgeons. But essentially, the target audience for the book ranges from the hip surgeon in training through to consultant orthopedic surgeons, which are focusing on hip arthroscopy. These are my disclosures, none of which are pertinent to the talk I'm giving. Hip preservation surgery, the idea was conceived by the principal editor, Nicola Bonet. I suppose all three editors are like the parents of this book. And I think of authors as the nannies. And we're preparing this book to be launched in the general society. So as you bring up a child, you want that child to be as well behaved, as well mannered to contribute to the society, which is that of hip preservation surgeons. When I read this book, what strikes me is that it's not fragmented. There is a flow. The editors have been very good at giving us a direction, so it doesn't seem fragmented when you read it. It's a continuation of a story, which then gives you solution to the problem that you might be finding in your clinical practice. Let's look at the chapter that I've been contributing on subspine impingement. That's the chapter 6 in the book. My co-author is Mohammed Adil Akhtar, who's a consultant orthopedic surgeon now in Edinburgh, and Richard Villa, which made it worthwhile a read. Let me read up how this opens. The book reads, subspine impingement is an extra-articular form of impingement around the hip joint. The word impinge is a verb defined in Cambridge Dictionary as to have an effect on something, often causing problems by limiting it in some way. Now, what I like about it is not just a book about hip arthroscopy or hip preservation. It tends to read rather well, and I hope the audience would enjoy reading it when they get the chance. We're familiar with the normal concepts of a hip joint morphology, the cam impingement, the pincer, and now we realize that often there is a mixed impingement picture. Let me add a red arrow just above the acetabular rim and just underneath the AIIS, and that is what we're talking about, subspine impingement. Let me go back to my favorite book on hip preservation. It reads, anterior inferior iliac spine gives origin to direct head of rectus femoris and iliocapsularis. It is entremedial to most lateral part of the acetabulum. The mean length of AIIS apophysis is 31.5 millimeters and a mean width of 11.9 millimeters. The AIIS prominence projects outwards a mean 6.4 millimeters. Ladies and gentlemen, focus on the next sentence. It says clearly an anomaly of height, width, and length can precipitate an impingement phenomenon. I mean, that's how simple and how easy this book reads. Here is me on my dining table, putting my index finger just underneath the AIIS and above the acetabular rim. The type 1 is when you have a concavity there. That's deemed normal. Type 2 would be when you've got an osseous bump there, which may become symptomatic. Type 3 is where my finger is, the prominence hangs from there all the way to the level of the acetabular rim. And type 4 goes beyond the rim itself. Let's look at a case study from the book itself. Here's a 26-year-old footballer. His championship footballer, groin pain, no distinct injury, but numerous groin sprains, intermittent time of training. A fader is strongly positive. The Faber was weakly positive, and none of the other structures were involved from spine to hernial orifices, etc. So I go back to my book. I see, what should I do? And the book tells me that you must do your plain x-rays in 2 views, look at both hips rather than just one, and do an MRI scan. It tells me consider doing a CT scan, a dynamic CT assessment, or a diagnostic injection, and consider doing a dynamic ultrasound scan. It gives me a whole heaps of rheumatological and hematological screening tests, which in this case I did not perform, but we did perform the imaging investigations as suggested. The book is also talking about my treatment options. So I look at the book, it tells me that institute physical therapy, I did. Do biomechanics correction, I did. Work on core stability, change the training loads, try a short course of NSAIDs. We did that for 12 weeks, but no difference. So I go back to the book as to what should we do, subspine decompression, but you must repair the support structures and you must address the CAM and if there is a pincer, and then do a functional rehab. I jump and skip onto a picture from the book. The right hip has got this sort of a bony lump. We spin around and we see actually, it gives me an impression there must be some trauma involved, but this impinging lesion is bordering on type 4. So I go on a lateral decubitus. The book gives you detailed impression of how to position the patient, how to access, and I get my standard access from my posterolateral portal. I take a diagnostic round. The ligamentum teres looks pristine. I find some chondrolabral damage. I make note of that, but I don't do very much there now. I look at my acetabular rim, which is the blue arrow, and I deliberately go for my capsulotomy rather higher up, about 12 to 13 millimeters above the rim. I then confirm myself that is my radiofrequency probe where I need to be. So this is an arthroscopic resection, not endoscopic. And before going too far, I actually start decompressing that bony bump that we were seeing to get access further superiorly. The red arrow is what we are working on. And I keep checking under the fluoroscopic screen that how far I've gone. So here we are. Capsulotomy is getting bigger because we're going higher up. We're above the reflected head of the rectus and we're below the direct head of the rectus. And here we are. We worked on it slowly with a high speed burr and we decompress the impingement lesion, but the work is not done. We go inside. We knew we had a labral tear. We stabilize it just like Matti had described in his chapter with an all suture anchor through a base repair. We work on the chondral surfaces, stabilize that, and the book describes in a dry setting with fibrin. We then take a separate portal and go into the peripheral compartment, find out that corresponding CAM impingement lesion. CAM impingement lesion under that red arrow is going to compromise the biomechanics. We need to actually address the biomechanics on both sides. We decompress the CAM. As you can see, it's not a deep resection. We're just interested in achieving dynamic control and stability of the hip joint. The patient did return to playing soccer in about 5 months after it. The book then discusses, it talks about that subspine impingement is a variant of femoroacetabular impingement and may coexist with AIIS impingement or exclusively as a subspine phenomenon. Often there is soft tissue damage that might need addressing. Hence an arthroscopic approach is strongly recommended even if endoscopic plan is employed. What I like about this book is it does not tell you what are the options. It tells you this is what the author would do, but outlines the other options in the background. I hope this book gives you the same inspiration while reading that we had while writing it. Thank you very much, and I hope you will read it.